Good. Welcome. Welcome, everyone. We have very talented list of speakers, panelists, and advisors for this virtual side event on the margins of 58th session of Commission on Population and Development. Names, email addresses, and short bios of these wonderful speakers are available on the website. The link to access of all this information will also be available. You can access through the chat box. If you have any questions, please hold it till the end or write in the chat box. Or best is contact the speakers directly. They will be happy to reply. The title of today's side event is Steps Towards Leaving No One Behind, Achieving Quality Education and Universal Health Coverage. Let's get started. Okay. I think I am getting good at it. Good. Okay. Women's Health and Education Center, WHEC, was established in 2001 to improve education and health needs. WHEC's chair program for research and educational organizations networks was launched in 2022 in collaboration with the UNESCO Higher Education Sustainability Initiative, HESI, to improve sustainability literacy for all, with special focus on women, girls, minorities, and migrants. It is fostering collaborative research, partnerships, and networks in both developed and developing countries. WHEC addresses this issue by reinforcing the coordination among key international organizations and national actors working on sustainable development policies and framework. Leading lifelong learning for a healthier world is our primary goal, and we invite you all to join our efforts. Ultimately, it is an investment in people and in a healthier, safer, and fairer world. This is our agenda and objectives today. Foster societies where everyone is included, expanding UNESCO Chair Program, promoting global collaboration, foster inclusive digital transformation, and fostering social justice, a collective responsibility. Knowledge generation and dissemination. Robust digital infrastructure and well-working digital infrastructure, including interoperable system, is essential for bridging the digital divide and enabling interconnectivity for inclusive global participation in science, technology, innovation, and health development. International support and public private partnerships for infrastructure development are key to enhancing access to stable and affordable electricity, mobile networks, and the internet. Sexual and reproductive health is critical to overall health and well being across the life course, and therefore has to be embedded and integrated with universal health care and universal access to all. Science and knowledge translation in reproductive health research and dissemination, exchange, and clinical applications of scientific knowledge with the healthcare providers worldwide was the objective of WHEC's practice bulletin when it was launched in 2006. Currently, there are about 300 practice bulletins on this website. Link LINK is an acronym, means Learning, Innovating, Networking for Knowledge Access Project. This was first introduced and presented at 2022 high-level political forum at United Nations. The main purpose of this link Access project is to disseminate evidence-based reproductive health research. It is serving in 227 countries and territories all over the world wherever internet is available. Leading lifelong learning for a healthier world is our mission, and we serve about 14 million healthcare providers every year. Clinical application of scientific knowledge. Women's Health and Education Center collects and disseminates progress, good practices, innovation, and research to support open educational resources and its implementation with the support of various teaching universities, internationally renowned open education communities. We aim to develop strategies to monitor the educational effectiveness of long-term financial efficiency of open educational resources, which includes participation of all relevant stakeholders. Such strategies could focus on improving learning processes and strengthening the connections between findings, decision making, transparency, and accountability for inclusive and equitable quality education and research. When we work together across groups, across disciplines, and across shareholder groups, we as humanity can harness science and technology to the benefit of all of us. What is urgently needed is to enhance international solidarity and cooperation and realization of global trust and partnership in digital health and research. Yeah, empowering women through education is the best way forward. Education and health have power to transform the lives of our children and future generations, eliminating poverty, hunger, and improving living conditions. Inclusive and transformative education and health cannot be delivered if our children are not safe, well nourished, and healthy, and free from violence and discrimination. There are growing numbers of studies that reflect the interrelationships between education and health, which necessitates a more comprehensive approach to school and coordinated action across sectors. When people are able to get quality education, they can break from the cycle of poverty. It is estimated that by 2030, there will be nearly 330 million people working to improve public health globally. The swift pace of scientific research, discovery, and advancements will require the health workforce to stay connected with the latest evidence based guidelines and to feel confident putting them into practice. Tools for our child development. WHEC's initiatives and development agenda focuses on and helps both teachers and students improve their learning skills. To help boys and girls stay in school, continue to stay focused on the productive future, to encourage girls, women, and minorities in STEM. STEM is an acronym we all know, the science, technology, engineering, mathematics, and medicine programs, to improve their learning potential and to help students learn the skills they need for leadership roles and good role models. We have just published Learning Life Lessons series for the purpose learn to live together, learn to be, and learn to handle life's challenges. Please feel free to review this series. Our projects programs are helping schools, educators, and students. Our focus is on health promoting schools, programs for youth development, mental health programs to prevent gender and gun violence, how to handle life's challenges for good mental health, emotional intelligence, and harnessing the digital revolution for benefit of public education. Now, summary and takeaway. Well connected and well operated digital infrastructure, including interoperable system, is essential for bridging the digital divide. Enabling interconnectivity for inclusive global practice in science, technology, and innovation and health development is essential. Sexual and reproductive health is critical to health and well-being across the lifespan and must be integrated in universal health coverage. Science and knowledge translation in reproductive health research and dissemination for the healthcare providers worldwide and communities is the purpose of WHEC's Link Access project. Leading lifelong learning for healthier world is our mission, and we take it seriously. Lastly, please review International Health and Developmental Portal via this link. Link has already been provided here. The portal supports capacity building for e-health and e-governance applications worldwide and look forward to the development and use of norms and standards. Thank you very much. That's me, and that's my email address. Feel free to contact me. Now, it is indeed my pleasure and privilege to hand over to Charlotte Berkwin. She is from WHO Academy. I think it's the best section of the whole WHO. So go ahead, Charlotte. All yours.
Thanks a lot, Rita, and thanks for inviting me to this panel. Let me just share my presentation. So, I can share my... Okay, well, let me just share my screen. Sorry, just one sec.
Good. It better work.
No?
No?
No? Okay, and now?
Charlotte, yeah, you started to, yes.
You can see it now, right?
Yes, I can see.
Great.
Good.
Thanks,
Perfect.
Rita.
Perfect.
So, hi everyone, and again, thank you, Rita, for inviting me to join this panel today. So, my name is Charlotte Berquin. I work at WHO, the World Health Organization, and I am the localization team lead for the WHO Academy. I am also leading the Academy work on gender rights, equity, and diversity. And I'm really pleased today to share with you how the Academy works toward localizing health education to help ensure that the team of today, no one is left behind in lifelong learning for health. We are all aware of the complex health challenges that we face today, from pandemics and climate change to humanitarian crisis. These aren't just global challenges. They are deeply local in how they are experienced by individuals, by communities, and of course by health workers. And yet, the way we prepare health workers to respond to these challenges often doesn't reflect this complexity. At the WHO Academy, we believe that health education needs to be adaptable, localized, and inclusive, designed to meet people where they are and who they are. The WHO Academy is a new transformative initiative of the WHO, created to build a unified entry point for capacity building on health and ultimately to transform lifelong learning for health impact. We are a center of excellence for lifelong learning in health, offering learning programs that are competency-based, that are multilingual, that are inclusive, and accessible. Our mission is to build competencies that improve health outcomes and health system performance everywhere for everyone. We aim to improve health outcomes globally by supporting countries in strengthening health workforce capacity, whether online, in person, or hybrid formats. I'll get back to that a bit later. Our overall objective is to increase the impact of learning and to support the achievement of several SDG, including, of course, SDG 3 and SDG 4. We work to integrate learning needs on current and emerging public health priorities at the global, regional, national, and community levels. And localization is at the core of this effort. A few words on our strategic objectives. So the work of the Academy and the strategy of the Academy. By the way, recently opened because we did the inauguration of the Academy in December last year. So our work is guided by 5 strategic objectives. As you can see them on the screen, they focus not just on delivering learning, but on ensuring that learning is equitable, impactful, and embedded in country needs. My personal work as the localization lead directly supports these different pillars, especially around access, inclusion, and fostering innovation in learning design. We are based in Lyon, so in France. While we are a global institution, we have the chance to have a state-of-the-art campus, brand new, designed to support innovation, face-to-face learning, and immersive simulation. As you can see in the picture here, we have a huge simulation center that allow us to reproduce diverse, realistic environments. We can adapt the environment. We can adapt the temperature. We can adapt the aerometry. We can adapt a lot of things to simulate different context, hospital context, as you can see on the images, but also natural disaster context, etc. It's a hub where global collaboration and local action intersect, and which is designed to create immersive and collaborative learning experience. Our courses are designed to meet the needs of diverse audiences, WHO workforce primarily, but also healthcare workforce in general, also decision makers in public health, and we try to really have courses that are tailored and adapted to the specific audience needs. We know that all health professionals need to continuously upgrade their knowledge and skills, and that learning needs to be available when and where they need it, in a format and in a language that is accessible for all. That's where localization comes in, and I'll get back to that a bit later as well. So at the Academy, we work across multiple thematic areas, from emergency preparedness to non-communicable diseases, and we have global programs that are the foundation of the work of the Academy, but localization ensures that they are relevant in diverse settings. So whether you are in a rural health center in Latin America, whether you are a midwife working in a rural community as a community health worker in Senegal, or in crisis zone in the Sahel, we want to make sure that the learning you access makes sense in your own context. We intend to have a global reach, as I've explained, through our multiple learning delivery modalities, while keeping in mind that global relevance is, of course, only achieved through local engagement and contextualized delivery. So we have different course formats. Of course, we have a lot of self-paced courses on our platform that I will present right after that. We also have blended learning with a mix of self-paced and instructor-led or face-to-face component. And we also have simulation and game-based learning. We have set up a dedicated learning experience platform. So you have the address on the screen. All our courses are free, are accessible for free, no cost to access the online courses. Learners can access content on mobile phones. They can also download materials offline. They can track their competencies over time. And our learning experience platform isn't a standalone technology, but it leverages a variety of existing learning methodologies to curate and aggregate a holistic learning portal. Our learning platform is already available for its interface in 25 languages. And we already provide or offer courses in over 20 different languages. So full courses are offered in over 20 different languages on our platform. We have also different format of creating courses. So we have co-created courses that are developed directly by the Academy with some WHO technical unit and other partner. We have hosted courses, so courses that have been developed by other entities or partners and that have been vetted by WHO Academy and that are now hosted on the WHO Academy. And we also have gateway courses, so that link directly to external courses, but that are relevant and that meet our quality standards and criteria. So they are referenced on our platform. Of course, equity in health learning is not just about offering courses. Despite global efforts, especially in the past years and with the rise of digital learning, we know that many of these efforts have been successful. But still, many health workers and learners remain excluded from these efforts due to language, due to cultural norms, due to disability, or due to digital inequities. Localization helps address these barriers, starting with language, but going beyond language and translation. We will see that after. So beyond just linguistic inclusion, we also consider cultural relevance, we also consider accessibility, and we design with the digital divide in mind, ensuring offline access, ensuring lighter formats for those in low bandwidth context, for those using maybe older digital devices. And we also try to have adaptable delivery models, as mentioned earlier. So now going a bit more in depth on the WHO Academy localization approach. So you can see on this slide our approach in a nutshell, which is strategic, participatory, and rooted in equity. As I said before, localization isn't just about translating words. It's about transforming learning to meet local needs and empower frontline health workers. Why do we think that localization matters? We think it matters because we want to expand access by reaching a wider audience. We want to drive impact by making all our educational content relevant and practical and adapted to local realities. And we want to foster equity by giving all healthcare professionals the means to improve, ultimately, the quality of care. Our key objectives, so we aim to ensure that all our courses are accessible, culturally relevant, and inclusive, addressing the diverse needs of global audiences while upholding the highest standards of quality and equity. We also think that health is an integral part of achieving gender equality. The WHO Academy is committed to providing content that empowers learners from diverse linguistic and cultural background to acquire knowledge and skills effectively. And our localization process reflects the Academy approach to be really learner-centered. Let me give you very quickly a few examples demonstrating how contextualization might increase uptake, relevance, and impact of courses. So for two of our hybrid courses, for example, so the Mass Casualty Management course, MCM, and the Basic Emergency Care, BEC course, we have localized this course in collaboration with WHO Technical Unit, with WHO country offices, local experts at national level to co-design and localize these courses. So, for example, to localize the BEC course in Moldavia, we have established a partnership with the Medical University of Chisinau to help make sure that our core learning content was relevant and adapted to the specific local content of Moldavia. We've done so with different courses in different contexts. And we are still, I mean, the academy is quite new, so the localization approach is also a work in progress, and we are still actively pursuing new partnerships with academia, with civil society, and with local institutions to improve our approach and to develop a network of partners to be really able to walk the talk in terms of having this relevant localization approach. So in conclusion, for this presentation, at the WHO Academy, we think that localization is not a technical afterthought. It should be a political and an equity imperative. If we want to achieve universal health coverage and truly leave no one behind, we need to embed equity in how we design and how we deliver learning to ensure that this learning reaches everyone, everywhere. And again, it's also a call for action to all of us. We look forward to building new partnerships, and we invite partners to join us in advancing health equity to a better inclusive, localized, and accessible learning to scale our impact globally and locally. And I'll stop there. Over to you, Rita. Thank you.
Thank you. That's a beautiful presentation. I hope we get a chance to work with you forever.
Thank you.
Yeah, it's indeed our pleasure to introduce you to Dr. Colleen Kraft again, and she's my best friend. Dr. Kraft is a professor of pediatrics at Children's Hospital in LA. She was 2018 president of American Academy of Pediatrics. And here is her presentation on universal health coverage for children and teenagers. Go ahead, Colleen.
Okay, well, thank you for that great last presentation, and just want to sink back a little bit to universal health coverage and really how it relates to our sustainable development goals. So we know that universal health coverage is defined that ensuring that all people have access to needed promotive, preventive, curative, and rehabilitative care services, and that people do not suffer financial hardship while paying for these services. There's a little bit of an interaction between universal health coverage, which is now the preferred language, and universal health care. You will find that most organizations use these two terms interchangeably. I think the reason that health coverage was actually adopted was because it implies that that payment is there and that we don't have to put people into poverty in order to cover their health care. The concept of universal health coverage is really this, is that if you look at how much healthcare is, where are the financial protections? What do we have to do? What do people have to do to pay out of pocket? What are the services that are covered and who is the population that is covered? And just like this box, you want to do the most efficient way of covering the most services, knowing that particularly for children and adolescents, prevention services are going to be the most cost effective so that those kids and adolescents who do have high cost health needs can still be covered by the revenue that's brought in, whether it's government mandated or privately. And these are some models about how universal health care works. So one model is single payer, and you see this in the United Kingdom. It is free government provided healthcare paid by income tax revenue. So every citizen has the access to government owned services. So the UK is the National Health Service is a good example of that. There are examples where you look at mandatory insurance. So government-run health insurance financed by a payroll tax on employers or employees, but it is given by private hospitals and doctors. And so those private hospitals and doctors are in contracts with the mandatory insurance so that they get paid for services. Germany does it this way. So in Germany, you have a health insurance plan or scheme. It is funded by payroll taxes, and then you go to your doctor who takes the insurance that you are paying for. And then another example, looking at Canada, is the National Health Insurance Program. So every citizen pays into a national plan provided by a single insurance company. But then those doctors and hospitals contract with a single insurance company. So it is publicly funded, but then privately delivered. So Canada does things this way. And if you look at the outcomes, and you look at even the Commonwealth Fund or other national and international organizations, the top ranked healthcare systems have universal health coverage. So if you look at this, Norway, the Netherlands, Australia, the UK, Germany, United States is way down there. But if you look at the chart next to it, the United States has the highest cost, but much poorer quality than many of these other places, primarily because we don't have universal health care or coverage. There's a history, and even in the United States, we have tried to get to universal health coverage, and it's been somewhat derailed, but it was actually almost 150 years ago that Germany became the first country to make nationwide health insurance mandatory. In 1933, when Franklin Delano Roosevelt looked to Social Security, he was actually very interested in funding a universal health care program as well, too. This was unfortunately eliminated from the final legislation. In 1948, the UK enacted the National Insurance Act and the National Health Service. So after World War II, the idea that universal health coverage and care was a priority was there. In 1948, the Universal Declaration of Human Rights states that health is an important fundamental right. Back to the United States, in 1949, Harry S. Truman proposed universal health care. And in 1965, Medicare and Medicaid. So in the United States, Medicare covers primarily people over 65 and then some chronic illness. Medicaid funds primarily children and people who live in poverty, 100% of the federal poverty level or below for the most part. Some states will go up to 200 to 250% of the federal poverty level. But Medicare and Medicaid were created by Lyndon Johnson with the Social Security Act and really the whole war on poverty. So what you're seeing the United States doing is they are providing universal health coverage to segments of the population, but not the whole population. In 1966, the International Convention on Economic, Social, and Cultural Rights recognized the right of everyone to enjoy the highest attainable standard of physical and mental health, really pointing to preventive services for healthcare. In 1978, the Alma-Ata Declaration looked at primary health care and that vision of health for all. In 1993, once again, the United States tried to get some universal health care and coverage into play with President Clinton, and this was not enacted into law. In 2005, the World Health Assembly Resolution 58.33 adopted the term universal health coverage. This is why you are primarily hearing that terminology. In 2010, we had yet another move forward that was incomplete. So President Barack Obama and Congress put in the Affordable Care Act, referred to as Obamacare. What that does is that has actually worked with different health insurance agencies in different states that do have lower cost health care, and then subsidies that have been traditionally provided by the federal government. But as we're seeing now in the United States, unless something is really written into law, it may not actually happen and things can be taken away. And so, where Obamacare stands is still a lot of people use it. It's very popular, but there are threats to it. And then finally, in 2015, the Sustainable Development Goals adapted universal health coverage as one of the targets, really looking that this is something that's very important for all people and should be part of those Sustainable Development Goals. So if you look at the Sustainable Development Goals agenda, target 3.8 looks at least 1 billion more people have access to essential health services, those primary health services, in each of the 5-year periods between 2015 and 2030. And the emphasis was really on community-based services with health promotion and disease prevention, and then immunization, because these are what we know in primary care give you the biggest bang for the buck and really help with health equity. Primary health care, again, was a cornerstone for achieving universal health coverage and the Sustainable Development Goals. And the approach is that there should be integrated health services with that emphasis on primary care and essential public health functions. So primary care is really seeing a provider of your choice in your neighborhood. You don't have to travel 100 miles to see that person. And that within that primary care situation, there are empowered people and communities, and that there are policies that help to create and sustain health. So knowing that you have to have immunizations before your child goes to school, knowing that you have to have lead out of your water, knowing that you have to be looking at different systems for improving quality of care, are really important, that there is a monitoring and evaluation system. So the results really look at improved access, utilization, and quality with improved determinants of health. So what are some of those essential services of universal health care and health coverage? So we look at maternal, newborn, child, and reproductive health. I'm going to focus a little bit on infectious disease. I'm going to talk a little bit about non-communicable diseases. And then finally, service access and capacity. So maternal, newborn, child, and reproductive health. One of the cornerstones of this is family planning, not something that's available or even in the mindset of some people in different places in the world. There are people within the United States who object to family planning because I'm not sure why they want to still live in the dark ages, but they do. But family planning is a cornerstone, that you have the right and that you have the resources to plan when you're going to have children, how many children you're going to have, how that's going to work with your life. Antenatal care and the idea of safe delivery and decreasing maternal mortality is very important. And this is something that spans the, what we talk about of high-income countries as well as low-income areas. I mean, in the United States, we know that there's a big difference between maternal mortality if you are Caucasian or African American. And why is that? And what do we have to do to get to that health equity? Full child immunization. We are running into all kinds of issues with this in the United States right now. We just had a second child die from measles in Texas. That child was unvaccinated. And full child immunization is as much a policy and policy driven as it is getting into the hearts and minds of families to recognize that there are diseases that kill children that don't anymore because we have immunization. And that message is something that is really important to get out there. And we really have people who are very lukewarm about this at the top of our HHS right now. And then finally, health-seeking behavior for pneumonia. And this really refers, pneumonia is one target, but health-seeking behavior for things that you think of that are symptomatic now, that if you treat them early, may be something that's very helpful for you. In the infectious disease realm, Tuberculosis treatment, still something very, very important because tuberculosis, if anything, in the United States, it's increasing. We see this here in Los Angeles. We have seen kids who have come across the border or the developed tuberculosis, and we have to be very focused on diagnosis and treatment. HIV antiretroviral treatment has made a tremendous change in lifespan and life quality in places that are under resources. And unfortunately, we have temporarily stopped those programs. Use of insecticide-treated bed nets for malaria prevention really speaks for itself. If you can prevent malaria rather than dealing with the acute illness or consequences, it's important. And then looking at sanitation as one of those metrics is important. Non-communicable disease. Some of the targets that have been looked at have been prevention and treatment of high blood pressure and prevention and treatment of raised blood glucose, which are all very much lifestyle oriented. Looking at cervical cancer screening, looking at tobacco and decreasing those smoking rates are all important too. And then looking at service capacity and access. How do you get to a basic hospital? How many health workers are there in your population? Where's the access to essential medicines? And then health security. Where is the compliance with international health regulations? You know, and again, these conversations are happening in the United States as well now. We have hospitals who are closing their beds to pediatrics and maternity. We have states that are maternity deserts where you cannot find a provider to help you if you are pregnant. So these are ongoing conversations, all related to universal health coverage. Very interesting looking at some of these metrics. Before COVID-19, we were still falling very short on that sustainable goal 3.8 target, with that goal of 1 billion more people looking and benefiting from universal health coverage by 2023. So if you look at the first three metrics there, looking at catastrophic healthcare spending, between 2000 and 2017, we actually had more people who were spending more than 10% or 25% of their household budget on health out-of-pocket expenses. Not the right way to be going. The second metric was a little bit better. So population with impoverishing health spending, as that $1.90-day poverty line of extreme poverty, we actually saw this decrease before the COVID pandemic. We looked at impoverished by out-of-pocket spending, and then the poor spending any amount on healthcare, and those metrics actually decreased. So we improved in that realm. Looking at the population with impoverished healthcare spending at the relative poverty line. So these are people who are already poor. And what we found here is that we actually are seeing them become poorer because of healthcare. So we have a long way to go with really hitting the Sustainable Development Goal 3.8 target. When we looked at COVID, this is a bar graph looking at why people didn't access healthcare. And of course, in the upper middle income versus low income, we see that financial reasons were a concern with upper middle income, but it was more than half of the concerns with lower income. COVID-19 actually was a barrier for a lot of folks, but fairly even, actually less with the low income, really because financial reasons were front and center there. Supply reasons. This is something we saw within the pandemic and very universal in that you might not have a healthcare provider available there, or the offices were shut down because of COVID. So we saw that there were some other challenges because of COVID-19, but many of these are actually coming back. The important point is that the out-of-pocket spending and universal health coverage, which means that people do not have to go into poverty to take care of their health, is still front and center important. So in conclusion, universal health coverage helps that financial protection of families. It provides greater equity and improved health outcomes. It's efficient, accountable, and transparent, and results in increased jobs, greater productivity, and reduction of poverty. So what we are looking for with this is better access, better quality, and health equity because we have universal health coverage, it remains something that we look at as a goal for the Sustainable Development Goals. Thank you.
Well, thank you very much. It's very eye-opening. Okay, now it's indeed my pleasure to introduce David DiSabito, and he is from my hometown, Springfield, Massachusetts. Finally, I've attracted somebody from my own place. Um, his topic is AI liaison and AI working group, and he's the chair at the College of Business, Western New England University, Springfield, Massachusetts. And he's speaking on leveraging artificial intelligence to achieve quality education and universal health coverage. Go ahead, David, all yours.
Um, Thank you, Dr. Luthra and Women's Health and Education Center. My talk today is going to be on leveraging artificial intelligence to enhance quality education and universal health coverage. And you had given me a nice introduction. One of the things that I'm also doing, I'm a founder of a startup company called AI Integrated Concepts, and we developed a high-speed assessment process that can evaluate student work, about 105-page papers in 1 minute. So it's a very powerful product, and what it's done is it's opened my eyes into what can be done in the um, in the world with AI integration. So I've been pretty much studied and buried myself into AI integration, research and development process over the last like 2 or 3 years. Now, um, what I want to do here is really ask a lot of questions and get us all thinking about how can we leverage artificial intelligence in education and healthcare, and AI is already shaping these areas, whether we're ready or not. And it poses forth the question, you know, will it narrow the needs gap or leave even more women in underserved communities behind? At least in my mind, I'm asking that question. So as we know that AI is being adopted, uh, I've done a little bit of research before this conversation today, and determined that about 15% um, growth rate in the next 5 years will happen with AI adoption. So how are we going to leverage this? So here's a historical perspective. As you can see, there's about a five-fold increase in AI adoption from 2017 to 2021. Notice that the graphs that the education side is on the left and the healthcare side is on the right. Here I've included basically the same graphs, but with a future projection, and you can see where the stars are. That's pretty much where we're at today. So in education, there's like an 82% adoption rate, and in healthcare, there's about a 77 percent adoption rate. And as I mentioned before, just worth re-mentioning, we're expecting over the next 5 years a 15% uh, future growth in those 5 years. So first thing I want to talk about is education and look at it from an education perspective. So if you imagine you're a teacher with 70 students, no internet, and limited time, we can ask the question, what if AI could quietly support you, not replace you, but in addition, help your students thrive? So AI isn't the future of education. It's honestly part of the solution today, but again, the thing that I want to know is though, although we're adopting it, the um, the explosion of new applications is amazing, and I'd like to encourage anyone, who's going to listen to this to look at AI, to experience and work with the AI and the newer uh, generative pre-trained transformers like ChatGPT, etc. Uh, because you're going to find that there's things that you didn't know about and things that you can imagine that you didn't imagine before. So I encourage everyone to think about AI. I know at our university, um, there's probably 30% of the faculty are very involved in looking at AI and AI applications and discussing how it's affecting the future and current um, uh, situation in education. And it's uh, it's about 60% that are sort of shying away from it and doing things the way they had always done. So I'm asking folks to use your curiosity and your imaginations. So questions, could AI help teachers do more with less? In overcrowded classrooms, could AI tools ease the burden of grading or tracking learning process, freeing up time for actual teaching? Um, can we extend learning where it's needed most? What happens when AI tools are built to work offline, which we're gonna, there's already capabilities of doing that. Um, in local languages, AI translation capabilities are increasing as we speak, exponentially. It's absolutely amazing what's going on with this technology. Um, could we reach students who've been historically left out? Uh, could students learn with AI and not just from it? There's some really interesting stuff. I looked at, you've heard of Khan Academy, I presume many of us. I looked at an AI program they developed called Conmigo, and you can it's available for teachers or for students and for different disciplines. And I found it to be amazingly um, powerful teacher, and it, it's it, it's very resource friendly in terms of you get one-on-one attention, where we know that teachers are stretched all over the world. And can smarter data lead to smarter policy? So, if AI can show us who's falling behind in real time, how might ministries and NGOs use that data to better target support and close gaps faster? A lot of the classes I teach, we're looking at data, and we're starting to use AI to analyze the data, which can be have a better eye than sometimes a human, and it can analyze way more data in much less time. So some interesting things to think about. So leveraging AI for education isn't a vision for the distant future. It's a question of where we focus now. If designed and implemented well, we can use AI to strengthen our teachers and to prepare learners for the world they're entering. There's been a lot of talk about students cheating with AI and using AI for cognitive offloading, but I teach a class in problem solving with artificial intelligence, and what I've really seen is the students expand their minds. So it depends on how it's applied. So we want to ask, how do we want to apply AI? We might focus on practical tools to improve access for women, girls, and marginalized learners. Um, so that's sort of thinking about leveraging AI for education. We can also think about leveraging AI for health coverage. So universal health coverage isn't just about access, it's also about equity and timeliness. Can AI help us expand access to health for all? Is kind of a question I was started to look at. So if we imagine a health worker hours from the nearest clinic faced with a long line of patients and limited tools, could AI offer timely, meaningful support um, to maybe triage, um, to act as a consultant? A lot of the research and work that we've been doing and learning and networking and talking to people is that a lot of us are thinking we don't want to, at least at this point in time, allow AI to sort of think for us or do things for us. Um, but we can use AI to really strengthen our capacities and our own abilities, using AI as a collaborator rather than maybe as a leader. So a few questions um, about thinking in terms of how can we leverage AI for health coverage. Could AI assist frontline health workers even remotely? With mobile-based triage apps, some workers can already access symptoms and determine next steps, even in low connectivity settings. Excuse me. Could this scale to support more communities? Can smarter systems catch gaps sooner? What if AI could help us track medicine shortages, maternal health gaps, or local outbreaks in real time? Might that allow ministries and NGOs to intervene faster and more precisely? And could AI strengthen our training and mentorship? And I firmly believe that it can here. I've experienced it at our university. So in places where continuing education is hard to access, could AI provide ongoing support through simulations, translated materials, or voice assistants that coach in local languages? So these aren't just abstract questions or ideas, they're emerging tools. As I mentioned before, I probably, if I had more time and preparation, I might show you a graph on the emerging tools and the explosion of different applications in the artificial intelligence realm, and they're for everything. They're for education, they're for health coverage, and they could go way into other areas that we're not talking about today. Um, the question is, how do we shape and scale these tools responsibility, uh, responsibly? AI won't solve every health system challenge, but um, maybe it helps us to extend care just a little further and a little fairer. So um, I think the main point of my presentation today is let's keep in mind what might we leverage AI when planning our new initiatives. So, you know, I don't know that in all of our minds, AI is part of our planning. It has been for me, and it's served me and my uh, peer group here really well. So thank you all, and thank you, Women's Health and Education Center. That concludes my remarks.
Well, thank you, David. It was an excellent presentation. Even I learned something about AI. For me, it was just the two words before this. Anyway, now here is Dr. Ganesh Maini. He's an adjunct professor at Carnegie Mellon University, Pittsburgh. And Carnegie Mellon is in Africa, Rwanda, Africa, and in Pennsylvania. This guy is in Pennsylvania. So go ahead, Ganesh, all yours.
Thank you, Rita, for the kind introduction and for inviting me again today. So I do a lot of human-machine teaming, teach courses, experiential learning. I think I'm going to amplify some of the things other speakers have already mentioned, maybe add a couple of things to it. Background, as you know, the digital divide exists. It's more than just access, right? It's speed, it's infrastructure, it's skills. Do you have the right background to use the devices and so on? So some interesting data. Internet inequality limits opportunities, right? Both with respect to education and innovation worldwide. So how do we bridge this gap? How do we create equitable global progress, like many of the other speakers have chimed in today? Learning thrives in extended families. We know that, even in low resource settings. That's a picture from Myanmar. Could be oral traditions. Grandparents are often the unsung heroes, right? On the left-hand side, you can see a lot of communities in Asia, Africa, percent of persons over 65 years old living with extended families. Great opportunity for imparting education. Multi-generational households can foster rich contextual learning. Everybody's worried about AGI. We don't know whether it's coming, when it's coming. But the most important thing is it can reveal our strengths, our weaknesses. Question is, how do we prepare for its impact if it comes soon? Like Stephen Marcher said in the New York Times, AI's true gift might well be exposing our limitations. So how do we team better? I tongue-in-cheek say, a couple of humans can get together in 9 months, you have the human replica, right? But the human complement, now that's a bit of a challenge. How do we architect that correctly? The goals of education haven't changed with respect to AI. This is some people I know. Beverly Wolf has guest lectured in my class. They talk about mentors, lifelong, life-wide learning, interaction data, so we can make data-informed decisions, universal access to global classrooms. Obviously, the mantra should be of the people, by the people, with machines, for the people, if you will. These are some challenges we put together for the 2020s a few years ago. Really, how do we serve humanity, not replace, using AI? Technology should amplify human potential, right? So can we get robots in nursing homes that can amplify the hard work the caregivers are already doing? Imagine devices that summon ambulances or diagnose conditions autonomously. You can put cameras in the nursing home. It doesn't have to have the full resolution, fall detection, things like that, right? By using stick images and so on. So that's what you should be thinking about. Any AI project or data science project is a triad. It's data, domain knowledge, and tools. Everybody has access to either the same or similar tools, DeepSeek, OpenAI, Claude, your favorite chatbot. But the data, the domain knowledge tends to be very regionalized. So we need to sort of pay attention to that. There are significant data inequalities. The text-based stuff is a little more uniform, but as you can see, all the darker patches on that map, it's US, China, Western Europe, where the data is being generated, be it text, be it video, and so on. So we need to reduce the inequalities with respect to content. This is something recently that I saw. This map sort of shows you the percentage of subprime folks from a lending or credit risk standpoint, right? So still a lot of work to be done, as you can see in the southeast. So anything darker is a higher subprime rate. So Hidalgo County at the bottom there, which there's an arrow pointing to. I think what do they say? 92% of the about 1 million inhabitants are one Hispanic. The subprime rate was 42% in 2021, right? So this is about financial literacy. I think April is Financial Literacy Month. Here is an interesting experiment from Jordan where using smartphones, they're providing lessons on financial inclusion, entrepreneurship, project management, etc. This is some work we are doing at CMU Africa. I think you alluded to it, Rita, developing recommendations for digital financial literacy. This is joint work with Professor Rita Luhanga, who's usually on these calls. I spoke to her this morning. She had an evening in Africa engagement, so she couldn't join us. Professor Chipeta from WHEC University and Patrick McSherry. This is some work at the bottom left. As a student of mine looked at low resource languages. Charlotte might appreciate this. So she looked at English, French, but then compared it to Hausa, Afanoromo, which was Galani's mother tongue. So using an early version of the chat box, you get sort of a score of 8, 9 in English and French. But in Hausa, Afanoromo, you get like a 1, 2, etc. I think Hindi, a different student, Hindi and Gujarati, came in at like 5. So again, goes back to not enough corpora are available. On the right-hand side is how do we do decision making in large groups? Can we divide and conquer and then have a chatbot sort of monitor those conversations so that can transmit information so that you don't lose the whole community consensus, if you will. This is a case study from Kenya. Some folks at Harvard did. Gen AI's impact can be uneven because folks who are not used to using Gen AI, they thought it's the magic bullet, so they gave it more harder tasks and so on. So the best use of AI also requires AI literacy. There are some very good examples of AI-powered radio lessons now. So use ChatGPT generative AI to generate content and then broadcast it using radio, right? So even using a low-cost receiver in a rural area, you can actually receive the content and so on. So that was very interesting. AI-powered WhatsApp math tutor. This is from Ghana. Wanted to underscore that digital public infrastructure, which doesn't suffer from the tragedy of the commons, could be very interesting. So some of the textbook examples come from the India payment stack, so establish identity-enabled payments, but then can also be used for healthcare, education, several all 3 spheres, health, wealth, and education. This is something recent. AI optimism actually is higher in some of the emerging economies. So you can see China is on the right-hand side. India is also right-hand side. This is from the Stanford 2025 AI Index report, which was just recently released. US and so on, people are still skeptical. So something to think about. This is again hot off the press from Anthropic. How are students using AI? So the good news is if you look at Bloom's taxonomy, they're actually using it for higher level cognitive tasks, critical thinking in education. So 40% of the people are starting to use it for collaborative output creation, right? So we've got to make sure teachers, tools work hand in glove with the students so there's no cognitive offloading and so on. So the call to action, I think, is fund open source AI toolkits, public-private partnerships, let AI catalyze SDG 4, not deepen the divides. I'm going to, I think, play a 2-minute video on the capabilities, current capabilities in that Anthropic report. I'll put that thing in the, it's a long report. I haven't gone through it. I'll put it in the chat. But this is an example of somebody was on my LinkedIn feed, Peter Gostev. He created this video over an afternoon using multiple Gen AI tools. But imagine using this for education. This doesn't have much to do with education, but gives you the example will, open your, he's opening the door to a brave new world is the way to think about it.
Lights flash, scene swap. No pause, just flow. Fast track, let go. Spin, rhythm, ride. Move fast, go right. Scene, side, lose track, ignite. Stop, push hard, don't stop. Shift, spin, rhythm, ride. Move fast, go right. Side, lose track, ignite. Switch flow, quick turns, let go, high pulse, deep dive, stay sharp, alive. In and out, no rule, no doubt. Beat hits, quick turn, dance now, let it burn.
I'll put the link for this also in the chat. I think this is a quote attributed to Confucius, right? I hear and I forget, I see and I remember, but I do and I understand, right? So it's about experiential learning. It's providing tools so that students can learn by doing. Thank you very much.
Well, thank you, Ganesh. Now is the Vanati Gopalakrishnan, Associate Professor of Biomedical Informatics at University of Pittsburgh, USA. And she's a founding director of Pitt's Vihar Center in India. She's also presenting on global partnerships for digital health and lifelong learning. And she is really very actively involved in establishing UNESCO chair program. Hopefully we succeed. Go ahead, Vanati.
Okay, let me see if I can share my screen. And thank you, Rita, for that introduction. Can you see it?
Yeah, it's
Okay, and I can just start my presentation in a second.
sure.
Is that good?
Yeah.
Okay, very good. So yeah, good afternoon, everybody. And as Rita introduced me, I shall keep it brief. But my name is Vanati Gopalakrishnan, and Vanati means the Milky Way in a very ancient language called Tamil. And I am an associate professor in biomedical informatics, but I'm also the director of the Probe Laboratory for Pattern Recognition from Biomedical Evidence. And this was founded actually in the School of Medicine in the year 2000 when I graduated with a PhD in computer science. And my thesis was combining AI with macromolecular crystallization, which was, again, some kind of pioneering thing that was happening at that time, as we do in universities when you get a PhD. So thank you, Rita and the WHEC, for inviting me to present this talk on global partnerships in digital health and lifelong learning at this CPD 58 event. And to me, actually, I kind of have to resonate with what Dr. Mani just said about learning by doing. So a lot of the work that I will present today is actually like hands-on stuff and ideas that we've cooked up. So I'll present what our vision is for Vihar, which is the Vijayalakshmi Innovation Center in Women's Health Analytics and Research. And this actually came about in maybe 1 or 2 years ago when we were trying to put together an interesting collaborative project with the KCDH, or the Koita Center for Digital Health in Mumbai in India, in the Indian Institute of Technology, along with Carnegie Mellon University, Africa and Rwanda. And we were trying to come up with something that would be a very meaningful effort, and it would be a global effort. So basically, in December 2024, Pitt announced this center, and my dean, Dr. Anantha Shekhar from the School of Medicine, basically appointed me as the founding director. The mission of this global innovation center that we're building actually has to do with how we can integrate we can look at women's health from an integrative kind of perspective, but not just women, but actually follow a female through their entire life cycle, starting with the placenta and modeling right from there. And why do we need to do this? I really think that in order for us to, we talk about universal health coverage, we talk about giving and giving. But really, true empowerment for women and girls comes when they can take things in their own hand and actually take their health in their own hand. And how can we as humans facilitate that? And so that's really what the task is in this particular Bihar center. And we basically want to see why is it females who make up almost half of the world's population, still we don't have equity of care? Why does it not even exist? And we should be doing a much better job of this. And with Bihar now having been founded, I am almost more than 100% certain, if I could be, that we are going to very soon accomplish many of these equity-related aspects. And its mission is to conduct world-class research and provide training that empowers women of all ages worldwide to enhance their health and wellness by using healthcare technology and AI. The vision is to become the world's premier innovation center of research and practice in evidence-based women's health and wellness across the lifespan. And the broad objectives of the center is to integrate with ongoing women's health research programs at the University of Pittsburgh and elsewhere across the globe. To grow and sustain itself by sponsoring research based on its priorities with an initial investment. We're hoping that the philanthropic pledge that they have pledged to set up the center is actually going to come through. If not, we will have to seek actually actively more philanthropy. But we want to start innovative and sustainable projects that are related to its mission. And today I will show you some of that progress towards that. We want to differentiate Bihar through world-class research and training in integrative modeling of women's health. So medicine in the Western world has actually been cut up so much into organs and more into minutiae. But when we're talking about women, we're talking about female, we want to think about health from a very holistic perspective. And that's what appeals to me about the UN and the UNESCO and the WHO. So let's see where we would go further with this. So this is a unique slide that came about where we wanted to define the research priorities of the center. And so these, if you see, are actually pillars that we will follow. And each of these could potentially become like departments within AI institutes or within biomedical institutes. We just have to see what that's going to be. But digital twin is one of the big goals. How would we create a comprehensive female digital health twin? And to start doing that, we want to be able to model female-specific health organs and their functioning in silico. People are already doing that. We need to integrate information. We want to simulate data generation for health across the female lifespan from real-world data. And we would like to have smart ways of collecting data, and so that we can have a much more efficient way to put together the female digital twin development. And Rita has assembled such a fantastic set of potential collaborators in the event. today in showing you how even a high school student, actually, we probably have to start learning from our younger generation now, is what I'm thinking, after seeing how quickly they take our work or ideas and run with it. So I'll show you a snippet of an example of a joint work that we have been doing. So multimodal LLMs, multilingual, we heard about multiple languages. Now AI can potentially be created to translate, do automatic translation. This has been something that Carnegie Mellon researchers started working on a long, long time ago. And now I think things will come together. We'll have clinical applications which with ambient intelligence, if you will, and how can we adapt those and conversational AI agents and so on to specific mental and physical health examinations. How can we combine text and speech and vision for multimodal intelligence? So that's one whole pillar. And then we have the concept of collective intelligence, where we could take evidence from multiple types of sources like the genomics, proteomics, and other types of biomarker data that's available for precision medicine, precision nutrition, because every person needs their own tailored, personalized medicine, if you will. And all of these can be combined together using man-machine teams, as Dr. Mani just talked about. And so there are many interesting concepts that are going to come about in this. And I did put a plug, I think, for a chapter that's going to be coming out soon. And yeah, so now this particular picture shows you that even the UN SDGs, the digital twin market or the growth trend is actually far greater than even the UN SDGs worldwide. And this is also an interesting concept because I wanted to show you that we can do digital twinning potentially as a service. So if we think of digital twinning, where we have a physical entity, and this entity could be things which collects data like through the wearable devices, using Internet of Things. You have medical device, you have smart devices. And think of it as something that we're going to collect from patient through their patient biological samples, like the cell, DNA, organ system, human body, the entire thing. And at the facility level where we have hospital, surgery, or things like that. So those would be other sets. But basically, if you look in the middle, the digital twinning part actually has a whole bunch of commonalities that are happening. And that commonality has to do with database, simulation, monitoring, validation, analytics, and optimization, and so on. And all of these can be applied to real-time health monitoring, healthcare education, and knowledge sharing, disease early prevention, which is what my lab has been doing for the last 20 odd years, early diagnosis, and so on and so forth. All the way to healthcare facility management, healthcare research advancement, tying into a lot of the things that people in this seminar talked about. To give you a very brief intro, we have a very rich ecosystem for innovation at the intersection of AI and women's health across the life cycle here in the University of Pittsburgh and its neighboring universities. And the whole environment is fabulous with several types of joint programs, medical scientist training program, neuroscience, and so on. It's all set up. We have the Maggie Women's Hospital and Research Institute, the University of Pittsburgh Medical Center, which is very famous and globally available to children's hospitals, Hillman Cancer Center, and the Institute for Personalized Medicine. So going quickly to our first project that we've been working on in terms of global partnerships. So the first project that we've been proposing to do is doing something we call CLIMB, and that is computational learning, inference, and modeling of biotechnology. And biotechnology is a really broad term, if you will, which has already been defined by the UN. And here we will have partnership with a entrepreneurship advancing nonprofit, and that's called TIE. And TIE Global is basically doing this at a much more global level, where they have like 12 countries they have reached and have 60 chapters. And this kind of a cross-sector partnership with academia, industry, and nonprofit to train high school students in AI and biotechnology with state-of-the-art is a very interesting concept. We've only just proposed it. So as you know, we keep working on things and hope that some of these proposals actually get funded. So we did a joint mentoring with Dr. Mani and myself of a Michigan high school student to generate a new innovative science project using a multi-agent chatbot system, using Crew AI to simulate real-world scenarios and healthcare team interactions for simulated patients with varying levels of postpartum hemorrhage risk. And I will show you a little thing about his Michigan Science Fair project by Max. And I'm not going to spend too much time on PPH because all of you are quite familiar with postpartum hemorrhage and its early detection. And I'm also not going to spend too much time on the large language models and the problems that it might potentially be creating. But I do want to spend a few minutes on the research objectives to show you how you can have agents, right? So you have agent and you have the environment, and the agent does an action, and the environment gives back, either you get a reward and so on, or the state changes and so on. So this whole concept is just called reinforcement learning. And this is what typically happens even in our own brains. And so one of the things we thought we would do is see if we can simulate virtual childbirth, basically environment where autonomous AI agents dynamically generate synthetic patient data, clinical scenarios, reasoning pathways, and so on. And we basically integrate large language models with medical knowledge bases. And the question was whether we could develop self-evolving AI paradigm to overcome the limitations of frozen, so-called, single-use LLMs, which are not dynamic in nature. And basically, what this means by self-evolving AI paradigm is that you want to develop a mechanism that enables large language models to learn from previous mistakes. And so that's why we basically combined a knowledge base with the LLMs. So how can this framework be applied to real-world medical LLMs for PPH risk assessment? We could train AI agents in the simulacrum to predict the PPH risk factors and potential complications based on dynamically evolving patient cases and clinical trajectories. So this comes to many aspects of education. So for example, simulation can be used for medical training, for nursing training, and so on in low resource settings. And doing such a thing can also give us insights, which can then lead to further policy creation and so on and so forth. So these are our longer term goals. And basically, what we have been doing is trying to create patients as patient agents, and we can do that automatically. And what we did was very interesting. Was we took one of our own papers, which we have actually just resubmitted our hopefully final revision to the Nature Publishing Group and NPJ Digital Medicine. And this is using electronic health record data from several unique hospitalizations between 2005 and 2022. And this had about more than 1 million unique hospital delivery hospitalizations. And from that, we asked how much percentage of people were going on to get postpartum hemorrhage. How many of them had any of the 4 T's, atony or trauma or thrombin-related issues for PPH. And how many of them had like hysterectomy and all these other types of procedures that happen to them post-PPH. And these things are basically numbers. And from the numbers, you can create potential probability distributions, which give you an idea of the occurrence of these types of events, or what are the risk factors, or what are the comorbidities that are associated with these types of conditions. So basically, we could, in places where we don't have data, AI could be used to generate these data. And so the simulacrum is basically a way by which you can simulate and create artificial data to kind of understand the process. And this is how we do that. We've just set up an OBGYN, an anesthesiologist, a patient, and we basically have a simulation manager and we control all of these. I'm not going to get into too much detail about this, but this is something we are building currently, and we will continue to do this. But I want to go quickly to this aspect that we could introduce such novel frameworks that overcome other kind of LLM-based limitations, and we could do continuous learning for structured case retrieval and rule accumulation without retraining. And the key thing to note here is that we can do artificial data generation, so we could have a simulacrum generated data set for any condition and couple that with a medical knowledge base. And if we do that, we can pretty much improve the accuracy for prediction and so on. So basically, it's a step towards medical evolution where real-world knowledge enhances simulacrum accuracy, proving that a hybrid approach combining synthetic data with real-world validation improves medical AI performance. So now switching back to the next project, which is the UNESCO chair. So that was to give you an idea of how we're basically working with young people and actually maybe learning from the young people, but sharing our ideas and our experience. And in return, getting a lot of very useful information back from them. So this is a fabulous win-win situation. And I hope that every country can do this, and every child gets that opportunity. Now, for global partnerships with respect to the UNESCO chair, Rita has been our glue. So the WHEC, or our NGO partner, the Women's Health and Education Center, which actually has a lot of goals that are aligned with Vihar, if you noticed. Dr. Luthra will be our partner. And she has already been working with Dr. Mani Ganesh and with Edith Luhanga from CMU Africa, and with Colleen Kraft, who's our pediatric medical expert. And basically, we are trying to put together this really nice UNESCO chair in global partnerships for digital health and lifelong education. And we are so thankful that we have a very supportive chancellor, Joan Gable, and the Dean Ananta Shekhar, who have really blessed this effort. And we hope to continue and build upon these, basically, all the work that we've been doing. With respect to Vihar, we have a new global partnership that we are forming with TIP Global with Dr. Wendy Mars. She has a beautiful project called HESI, where she is developing apps, digital health apps that are tied up to where the consumer or the people in Africa and Rwanda. So actually, Edith will be working with her on this. And to be able to make the access to healthcare localized and much more easy through a digital interface. So basically, she's working, and Edith works on human-computer interaction as well. And so these are the ways in which AI can get involved to enable better interaction for better access to healthcare and doctors. And with Meggie Women's Research Collab, we've recently just submitted, actually Dr. Adibi did this, Joan Adibi, and she is actually an epidemiologist and an endocrinologist who's actually worked with placental environmental hazards and so on, has her own laboratory, and is now looking for very interesting ways to work with Bihar. And we submitted something with her colleagues in Brazil to get for a project on microplastics and stress, which are actually overlapping domains that indicate maternal environmental health in pregnancy. And we would love to do further experiments to just make sure that we have enough data to show the impact of microplastics on placental development. For Other partnerships, we are exploring with the Innovation Institute, an interesting funding we just put in for postpartum agentic support for new mothers. And this is an interesting project, I think, that came out of CMU Tepper called a class project called Auntie.ai. And basically, Auntie.ai is a very cute platform. If you search for it and go there, you'll see Ashley Real is the founder of this Auntie. And she and Sahil Shah, we're working together on this project. And basically, it's a cute thing which could potentially be translated into multiple languages, but it's a chatbot. And this chatbot has been evaluated on 100,000 people already, where it offers a very natural, like agentic support for new mothers who are having postpartum depression or getting into postpartum depression, which in the United States has become very common. And we do not know how many of such cases exist worldwide. So we are trying to see if we can create these type of digital health platforms, which can be expanded and scaled into not just support for postpartum. It could be a different, the underlying agentic support could then be used for other types of agent building. I will skip the other couple of things and just go straight to the multidisciplinary team and what we are planning for the UNESCO Chair in Global Partnerships for Digital Health and Lifelong Education. So here we are basically have these goals, and this is what we plan to do. We would like to develop and disseminate open access educational programs tailored to underserved communities, something that the NGO WHEC has already started doing, and our partners. So we will partner with you, and we will just continue to develop novel and newer programs as based on these themes of digital health and health for all. Then we will design scalable wellness protocols through digital health interventions that are culturally responsive and globally adaptive. And this was one of the goals for Vihar, setting up Vihar. And I'll come to that last slide where I'll explain why. We will also build international capacity through mentorship, training, and professional development for the health and education workforce. Dr. Colleen Kraft has already started doing that, been doing that for a long time with her impact program from the Los Angeles Children's Hospital of Los Angeles. And Dr. Mani and Rita have also been doing this. So Dr. Mani, through his mentorship with the FINIA, which is like a more financial inclusion program that he and Edith have helped develop in CMU Africa, and so on and so forth. So we will build upon what we've already started working towards. And we will inform global policy through evidence-based advocacy and strategic engagement with all of you. So algorithms for healthy aging, and this is what actually led to the formation of Vihar and the mission and vision and everything downstream. After having spent about like 23 years in looking at biomedical data from diverse diseases, all from head to toe kind of thing, including gut microbiome and so on. This was one finding, and I will, this is available as a paper too. And it's called global chronic disease burden can be reduced by taking care of our mitochondria. And so basically, this concept of algorithms for healthy aging is something that we could develop into a digital health program and a digital health tool. And the novel aspects of this first algorithm for healthy aging, and there'll be more to come, we can write books on it, I'm sure, which are culturally shaped and tailored to the specific environment in which the persons are living. So we can do that. So mitochondria-centered framework, it has a bioenergetics and mind-body connection, and it has a personalized community-based health recommendations options that we can tailor towards. And this approach aligns directly with United Nations Sustainable Development Goals, suggesting that health interventions should respect local lifestyles and environmental factors. And I think as we create more and more ahas, which are based on this underlying framework, but expand them to be more culturally adaptable and approach aging across the lifespan. I really think that we will be empowering the global community.
Sorry
And
to interrupt.
yeah.
We are way out of time.
Okay, sorry. Yeah, this is the last slide.
Finish it. Yeah, last, please.
Yeah, last slide. And we have all of these resources within the universities, and thank you so much. So we have the Children's Hospital of Pittsburgh, Children's Hospital Los Angeles, Maggie Women's, and all of this. Thank you so much.
Well, thank you very much. It was a very inspiring, and I'm glad from our friends from Academy, WHO Academy, Charlotte is still there. She hasn't abandoned us, because now I was telling you, when I saw you are interested in joining, that's what we were planning, submitting. We are almost ready to submit to UNESCO this chair thing, and it'll be financed. Don't worry about the finances. So, well, thank you very much. And if you have any questions, please contact the speakers directly, because we don't have any more time. We have gone 5 minutes extra. But we hope to see you for the science initiative in May, 7th of May. Some of you, and hopefully Charlotte, definitely. And I have also applied for the High Level Political Political Forum, HLPF, which is in July at UN. And I usually get it, so I've submitted that. So let's see. So we have plenty of areas to talk about. Well, thank you very much. I am going to stop recording.